Hello, my name is Francisca Echiburu, and my presentation focuses on health insurance disparities and unintended pregnancy among reproductive aged women in California using data from the 2023 California Health Interview Survey, or CHIS. To start, unintended pregnancies, so those that are either mistimed or unwanted, are a major public health concern in the United States, with nearly half of all pregnancies reported as unintentional. This statistic has significant downstream consequences. So it has been found that unintended pregnancy is significantly associated with higher odds of adverse maternal outcomes like depression during pregnancy and postpartum, as well as infant health issues like preterm birth and low birth weight. In addition, a parent who has not planned for a pregnancy could have less financial or familial support compared to someone who did plan. And while some studies show a modest decline nationally, there are still disparities. These inequities are often highest among women with lower income, less education, and those with limited access to consistent health care. So understanding how social and structural factors drive these outcomes is essential for promoting reproductive equity. So why insurance? This study hypothesizes that the unintended pregnancy rate will vary significantly across insurance groups. The role of insurance is a very critical determinant of care. Coverage influences the cost, continuity, and scope of accessible reproductive services, which includes everything from preventative screenings to education and to high-cost, long-acting reversible contraception, which are devices like intrauterine devices, IUDs, or arm implants. And lack of insurance means facing the highest financial barriers, which can directly impact an individual's ability to consistently use an effective birth control method. For my analysis, I focused on three primary groups that represent distinct levels of access. Private coverage, typically the most comprehensive, and it's often tied to employment. This serves as the reference group for the analysis. Also, public or Medi-Cal coverage, which is a very important safety net for low-income Californians, and the uninsured population. So the context in California is very unique. So beyond the Federal Affordable Care Act expansion, the state has programs, for example, one called Family Pact, which is a state-level access program that provides free reproductive health services to low-income, uninsured, and underinsured individuals. And I have professional experience working with enrolling patients in this program, so I had a special interest in examining if there were still significant gaps remaining, despite these strong state-level safety nets that would otherwise cover those who are uninsured or underinsured. So even though there is a well-known link between insurance and health, there are still important gaps in the literature that this study aims to address. So first, many previous studies relied on national data sets, which dilutes the state-specific policy effects, or they focused on narrow subgroups like first-time parents. And this leaves a major gap in understanding the experiences of reproductive aged women in California. And second, much of the existing evidence is outdated, which predates recent significant policy and demographic shifts in California, especially since the overturn of Roe v. Wade in June of 2022, which eliminated the constitutional right to abortion nationwide. And lastly, while the literature consistently points to associations between low income and certain racial or ethnic minority groups with higher unintended pregnancy rates, there is limited insight into how these factors intersect with insurance type. So understanding if insurance disparities are a proxy for poverty, or is it an independent, or does it contribute an independent risk? My study's contribution is to use current state-level data from CHIS 2023 to provide clarity on these intersections and structural disparities in a policy environment designed to minimize them. This analysis leads to our main research objective, which is to evaluate the association between insurance type and unintended pregnancy among reproductive age women in California, while accounting for important sociodemographic determinants of health. To achieve this, I have 4 specific aims. First, to estimate the prevalence of unintended pregnancy among women aged 18 to 44 by insurance type. Second, to assess the core association between insurance type and unintended pregnancy using a multivariable analysis, adjusting for 5 sociodemographic confounders. Third, to explore a potential pathway, so examining whether access to contraceptive counseling mediates or explains part of the relationship between insurance type and unintended pregnancy. This is measured by knowing whether the participant received contraceptive counseling in the past year. Lastly, based on evidence in the literature which suggests that disparities are often more prevalent in younger populations, the 4th aim is to assess the potential effect modification by age on this relationship. Moving into the methods section, this is a cross-sectional observational study using secondary data. Our data source is the 2023 California Health Interview Survey, or CHIS. CHIS is administered by the UCLA Health for Health Policy Research and is a large-scale population-based health survey. And the study utilized the publicly available adult data file. CHIS is ideal because it provides the state-level data that is necessary to capture California's population diversity and policy landscape. And because this used secondary analysis of de-identified public data, this study was exempt from the IRB review. All right. The CHIS 2023 survey population is the non-institutionalized residential population of California. For this study's purposes, the final sample was limited to women aged 18 to 44. The CHIS survey uses a multi-stage sampling method, including an address-based frame and a supplemental cell phone sample with geographic oversampling in counties such as Santa Clara, San Diego, and also the city of Long Beach, which is designed to ensure a representative sample of California's diverse population. The final analytic sample was determined through list-wise deletion, meaning we excluded records that were missing data from any of the core analysis variables. This resulted in a final unweighted sample size of 2,678 adult women for all analyses, which included 97 cases of unintended pregnancy. Onto the core measures. The outcome is a dichotomous variable. Having experienced an unintended pregnancy in the past 12 months, answered either yes or no. The primary exposure is health insurance type, which was collapsed from 9 original categories into 3 for analysis. These 3 groups reflect the main dimensions of coverage. Private insurance or private coverage serves as the reference group for this analysis. Public and Medi-Cal coverage groups together Medicare, Medicaid, and other public plans. And lastly, the uninsured group. I also want to mention a statistical constraint here. Because there were only 97 outcome cases, most of the categorical variables needed to be collapsed into either 2 or 3 groups just to have enough events per variable for a reliable regression analysis. And this included needing to collapse the age categories significantly into just 2 groups. To get an accurate estimate of the independent effect of insurance, I included 5 sociodemographic variables in our multivariate model to adjust for confounding, seen on table 1 on the right. Similar to the exposure and outcome, these variables were collapsed into either binary or 3 category groups for statistical power. For example, poverty status was dichotomized using the 200% federal poverty limit threshold, which is a standard marker for economic vulnerability and also public assistance eligibility. As mentioned before, age was dichotomized using a 35-year cutoff, so comparing ages 35 to 44 compared to 18 to 34, which aligns with the clinical definition of advanced maternal age and the changes in fertility risk. Race and ethnicity was grouped to allow comparison between the 2 largest California ethnic populations, so Hispanic and white non-Hispanic. The rest of the races were grouped together to meet the events per variable standard. Marital status was grouped into either married/living with partner or non-married or partnered. These confounders are important because they all influence an individual's insurance status and their underlying risk for unintended pregnancy. To formally conceptualize the relationships between the variables, I created a directed acyclic graph, or DAG. This diagram visually illustrates the theoretical model. The total effect runs from our exposure, which is insurance status, to the outcome, unintended pregnancy. The 5 sociodemographic variables I discussed previously, so poverty, education, age, marital status, and race and ethnicity, are positioned as confounders because they can influence both the exposure and the outcome. The graph also shows a proposed mediating pathway, which is marked as M1. This is the path from insurance status through contraceptive counseling to unintended pregnancy. And the mediation analysis will test if better access to counseling is the key way that insurance reduces unintended pregnancy risk. Moving into the preliminary results, this table summarizes the 2,678 analytic sample size. While I still need to apply the survey weights, these unweighted numbers clearly illustrate the characteristics and baseline disparities. So for the sample breakdown, our exposure variables show that 71% of the sample has private insurance and 29% fall into the public or uninsured groups, which are the primary groups of interest in the study. Second, the unadjusted prevalence. So these tables for AIM-1 show a disparity already. The unweighted unintended pregnancy rate among those with public or Medi-Cal coverage is 5.53%, which is almost double the rate seen in private insurance group, which is at 3.04%. The fact that the public group has a higher rate than the uninsured group shows the important reasoning behind confounding. This suggests the need for our adjusted multivariate analysis to determine the independent risk. My next analysis I plan to conduct is addressing AIM-2 using survey logistic regression to calculate the adjusted odds ratios. The table shown here represents the output for this model. The goal is to isolate the independent effect of insurance type after controlling for the 5 sociodemographic confounders. I hypothesize that once we account for confounding, the uninsured and public or Medi-Cal groups will still demonstrate a significantly elevated adjusted odds ratio for unintended pregnancy compared to the private coverage reference group. And these will be conducted using the appropriate replicate weights. For AIM-3 mediation, I'm testing whether the association between insurance status and unintended pregnancy runs through our the hypothesized mediator, which is contraceptive counseling. This shell shows where I will quantify the indirect effect, which is the percentage of the total insurance disparity that is statistically explained by the differences in counseling access. For AIM-4, which is effect modification, I will test a interaction term between insurance status and the collapsed age group. This will tell me if, for example, the disadvantage of being uninsured is magnified for younger women compared to those nearing the end of their reproductive years. All right, thank you so much.